Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Imaging and Vice Chair for Education at Memorial Sloan Kettering Cancer Center in New York City. How do we evaluate treatment response on imaging? Treatment response can be assessed in the clinical setting, whereby we evaluate using routine imaging such as CT or MRI with generalized interpretation. A second aspect of evaluating treatment response would be as part of a clinical trial. Many patients undergoing treatment may be placed on clinical trials. Those trials have specific response evaluation criteria. For example, one of the most commonly used ones is called RECIST 1.1, Response Evaluation Criteria in Solid Tumors, which is what it stands for. The way that works would be to select 5 target lesions, a maximum of 5 target lesions total, with no more than 2 target lesions per organ. The size of those lesions have to be at least 10 millimeters in the longest diameter on an axial image on CT or MRI. If lymph nodes are chosen, they have to be at least 15 millimeters in a short axis on CT. And if bone lesions are chosen, they have to have an extraosseous soft tissue component that measures as more than 10 millimeters. Non-target lesions can be also included, and those would be lesions that don't fit some of these criteria, or lesions in excess of the target lesions. If, for example, you want to include more than 2 lesions per organ or more than a total of 5. If you see lymph nodes that are not quite up to the 15 millimeter short axis and are somewhere between 10 to 14, but are suspicious and know that they represent metastatic disease, may want to include those as well. And other non-measurable disease, truly non-measurable, such as lymphangitic spread of tumor, leptomeningeal disease, peritoneal carcinomatosis, ascites effusions, which are lesions that cannot be measured in a straightforward sense. And any bone lesions that may not have soft tissue component but may want to be included. The response criteria also look for the, have really 4 different categories. Complete response would be if a lesion completely disappears and all pathological lymph nodes have decreased to a measurement of less than 10 millimeters in short axis. Partial response would refer to at least 30% decrease in the sum of diameters of all targets, taking as reference the baseline sum diameters. Progressive disease would be at least 20% increase in the sum of diameters, as used as reference, the smallest value during the study, which may also include the nadir, but also can include the baseline, and must also document an absolute increase of at least 5 millimeters from the sum of diameters. And stable disease would be something that neither suffices as partial response or progressive disease. Any new lesions would be considered progressive disease. Now, many patients nowadays are placed on checkpoint inhibitor immunotherapy, and these criteria may not apply as well. Therefore, a new system for evaluating response, which is IR RECIST, which stands for immune response evaluation criteria in solid tumors, has been created. Now, the mechanism of action of checkpoint inhibitors can lead to tumor infiltration by immune cells, which can cause a transient increase in the tumor size in patients who, in fact, are benefiting from this treatment. This is termed pseudoprogression. In such cases, tumors which are undergoing an anti-tumor immune response actually enlarge on radiological studies, and new lesions may be seen to develop in previously occult metastases. Many patients with such an initial response ultimately go on to have late durable responses. This type of response, as I mentioned, cannot be adequately captured by RECIST 1.1 because during using those terms, any new lesion or an increase would be considered progression of disease. Therefore, IR RECIST 1.1 has been developed. And in this instance, the development of new lesions does not automatically denote progressive disease at follow-up. And radiologic progression should be confirmed with follow-up imaging at least at 4 weeks to account for this possibility of pseudoprogression. Also, I'd like to bring attention to the fact that numerous treatment-related side effects are described, and it's important for radiologists to recognize these to ensure that they're labeled as side effects or complications and not progressive disease, and to ensure appropriate treatment and to avoid this misclassification as worsening tumor.